Our next speaker is Dr. Selim Corbacioglu, who's well known in the field of pediatric hematology oncology. Dr. Selim Corbacioglu is a professor of pediatrics and chair of Department of Hematology, Oncology, and Stem Cell Transplantation in Children's Hospital of Regensburg. His interest in stem cell transplant and the haplo transplant field and the T-cell depletion, and in the field of hemoglobinopathy and gene therapy in particular is well known. And we're glad to have him today to enlighten us about updates on hemoglobinopathy. So Dr. Selim, welcome to our conference.
Thank you so much, Abdullah. It's nice to hear your voice. Unfortunately, I'm not here present in person. Can you hear me? Can you hear me? Can you hear me also? Wait a second.
Yes, doctor.
You can hear me. Okay. So, well, then let's get started. These are my disclosures. And when you look at the map of sickle cell disease, you can clearly see that the majority of patients do not reside, of course, in Europe. We have approximately 4,000 plus patients. Plus means that many of the sickle cell patients in particular are not seen by hematologists for a long period of time, but rather by general practitioners who deal with, the pain crises and all the other issues, which is, I think, a huge deficit in our country. How about thalassemia? Again, the situation is very similar. We have approximately 400 plus patients in Germany, and as we all know, the majority of patients are in, the Mediterranean strip from, western part of Spain all the way down to Indonesia and Southeast Asia. And I think now you can stop laughing because most of them was kind enough to provide me your data with more than 80,000 patients that are affected, and you say 10,000 patients need a transplant. I think rather that most of the other patients need a transplant as well. And in order to address this very particular prevalence in your country, I'll try to answer the following questions. Number one is, should we offer a curative option to every patient with hemoglobinopathies? Number two is, should we consider a hemoglobinopathy a non-malignant disease? A very tricky and mean question. Can we offer a curative approach to every hemoglobinopathy patient? Number four is, are transplantation or gene therapy competitive treatment options? Number five is, are haploidentical transplantations a feasible alternative to a matched sibling donor or MUT transplantation? And last but not least, when should we offer a curative approach? Well, first question. When we look at the survival curves of sickle cell disease, starting in the 1970s of the last century, we see that the overall survival curve is significantly improving in these patients. But we are basically back to square one in the 90s, where we had supportive care, transfusion, and chelation, as well as hydroxyurea as the only treatment options, because the most encouraging drugs, crisanelucinumab and voxelotor, basically died on 2024 and 2023 due to inefficacy and unexpected high adverse effects. And overall, even applying best supportive care for these patients, the overall survival in African American in the United States, where you have really comparable experience with a high prevalence, very much like in Saudi Arabia, the overall survival of these patients is significantly worse by more than 20 years. And I'm not talking about quality of life. What about thalassemia? Milestones on the right-hand side, starting with transfusions in the 1960s, all the way down to the Farazirox in 2003. And the Kaplan-Meier curve on the left-hand side does not reflect the impact of luspatercept yet. But nevertheless, data by Fournier et al. In 2022 show clearly that over the last 20 years, again, the overall survival of these patients has not improved. So there's a significant unmet need for a curative approach. Now, the tricky question, should hemoglobinopathies be considered non-malignant diseases? Well, if you ask a physician, you might say, well, with thalassemias, you come to get your transfusions every 3 weeks and your chelation, you're fine. If you ask Ask a patient himself, he will tell you, well, sorry, I want to go for a whatever safari in Africa for the next 8 weeks. Where can I find proper transfusions and proper care if I'm in trouble? And if you ask a sickle cell patient, I think he will be very upset if you consider his disease a non-malignant. But for a transplant physician, it is considered a non-malignant disease, such as severe combined immunodeficiency and aplastic anemia and so on and so forth. But there's a major difference between these non-malignant diseases because sickle cell disease and thalassemia have a obligatory transplant indication. So you can transplant them today and you can transplant them 20 years down the road. And that makes a challenge or poses a challenge for the transplant physician and the patient to consult them when to go for transplant. And in the end, this situation with a non-obligatory transplant indication has to raise our approach and our restraints and our discipline to transplant these patients to the highest level. So we expect a rapid engraftment, low risk of infectious complications, minimal risk of systemic vasculopathies, next to no acute or chronic GVHD, at best a disease-free survival of more than 95%, and of course, preservation of fertility. This would be the optimum we should really ask for our hemoglobinopathy patients. And this question is to be answered if curative approaches can meet these requirements. Now, can we offer a curative approach to every hemoglobinopathy patient? Well, what do we have to offer? Number one, stem cell transplantation, matched related donor transplantations, and alternative donors, which is mostly haploidentical transplants these days. And on the opposite end, as we have heard from the other talk before, gene therapy, which is an autologous transplant from either genetically modified stem cells or a globin addition process where a viral vector is introducing alternative beta globin chains. And I'm going to start with matched sibling donor transplantation as standard of care. We consider it standard of care, but we have to be very much aware of certain problems that we are facing doing that. Because number one, there's age as a major denominator for outcome. Event-free survival, overall survival, and in particular chronic GVHD is rising when patients are transplanted beyond 15 years. And 15 years is still an adolescent and young adult that needs to be consulted differently than when you're talking to a 5-year-old or the parents of a 5-year-old with regard to these complications. Same is true for mud donor transplantations, but in the MUTs, there's the issue that like in acute leukemias, the outcome depending of a MUD or matched sibling donor transplantation is again different with a chronic GVHD incidence of up to 31%, which I think is not acceptable in sickle cell disease. In the end, again, this might be a rhetorical question because donor availability is below 20% for sicklers and almost as much for thalassemia as well. So there's a significant unmet need for cure that must be addressed with alternative treatment options. Now, we start with gene therapy, gene editing before, and I will keep it short because you have heard a similar talk before. It might be a little bit more critical here. We have available genetics, the gene addition approach with a lentiviral vector, and we have the gene editing approach, and I will focus a little bit on Vertex, but a little more on Beam Therapeutics that just presented very nice data. The principle of gene editing is very clear. There's not much to talk about that. The timeline below, again, was given to me by Mohsen, who, of course, in your country has lots of experiences already with gene editing. And the point here is that the process taking the patient from patient identification to the time point where he eventually is ready to go for conditioning can be up to 12 months. This is a logistical issue that we have to face because you talk to the patient, he eventually consents to a procedure that is new, that can carry certain risks, as we have heard before, and keep him online for that long period of time might be a challenge for the patient psychologically, but also for the treating physician. We know that Vertex CRISPR-Cas-based editing double strand breaks, knocking out BCL11A, de-repressing gamma chain transcription, and therefore upregulation of hemoglobin F production. These data are very well known and published. We have a vaso-occlusive free period that is achieved by 100% of those patients along the way in the trials For thalassemia, the same 98% of the patients achieve transfusion independence. So we have a very efficient curative treatment option for these patients. But there are some caveats here that we have to consider. We have persistent hemolysis, a persistent reticulocytosis, slightly elevated LDH, and the haptoglobin is on the lower level here, or on the subnormal level here. And it might be due to the fact that the editing process still leaves approximately 60% of hemoglobin S in the system. Number two, there's in sickle cell disease poor mobilization and insufficient collection. So the manufacturing of gene-edited stem cells is a very wasteful process where we need 20 to 25 million CD34 positive cells to eventually start manufacturing and having at the end a sum of 4 to 5 million CD34 positive cells that are genetically modified. And this is reflected in the apheresis cycles that are on median 3, but can reach 5 or even higher. And approximately 20% of collections are collection failures in sickle cell disease. You can improve this by trying to add GCSF to the plerixafor mobilization that is obligatory, but you have to be aware that the licensing information clearly states that the use of GCSF is not recommended in patients with sickle cell disease due to significant crisis that can be triggered by using this drug. And there was also an editorial to a publication most recently by Arcioni that stated that really be very careful with using GCSF in mobilization. It might work, but if it doesn't really work and cause trouble, you are in an issue that in a situation that might be not so nice. Plus, there are additional strategies around the corner or already available, which is optimization of the apheresis process, plerixafor dose optimization, and new drugs like motixafortide with a higher affinity for CXCR4, so that you can improve your mobilization cycles without the addition of GCSF and other drugs that you see down there. So there is help around the corner, and I think we should be very careful with using GCSF in these patients. There is delayed engraftment for sickle cell disease and thalassemia using the double-strand break vortex approach. Time to neutrophil engraftment is 29 days on the median, but can be as high as 56 days. Time to platelet engraftment is up to 200 days, which is far too long. Very similar data we see here for the TDT and, for the sickle cell population in the second table. Last but not least, but this is an issue with all the gene editing approaches, is busulfan conditioning. Busulfan is a horrible drug. It has high epi and endothelial toxicities. We know that the incidence with single conditioning with busulfan in TDT can be as high as 15%. And as we know, there are already fatalities in an 8-year-old child due to busulfan conditioning, only consequence of severe veno-occlusive disease. Busulfan passes the blood-brain barrier. We don't like that. We see high levels of PRES, in particular in the sickle cell population. And of course, busulfan has a very narrow therapeutic window. We all do serum level measurements, but when you do round robins and proficiency testings, you suddenly see that the levels and the cumulative AUCs between these different labs can differ by more than 20 to 50%, which I think is not acceptable. So we really need proper proficiency testings, standardized approaches, and external quality assessments. And last but not least, again, the patient information sheet says, consider prophylaxis for hepatic veno-occlusive disease prior to initiating busulfan conditioning. And for Litvia, the product by Genetics, it states literally use defibrotide for prophylaxis of veno-occlusive disease while doing gene editing or gene therapy in this case. The problem is there's no drug licensed for prophylaxis of veno-occlusive disease. Now, around the corner comes now gene editing 2.0, and Gupta et al. Published most recently data on base editing for HBG1 and HBG2 promoters for sickle cell disease that I think are quite remarkable. So the difference is here, we are using an adenine-based editing. There are no double-strand breaks, and inosine later on is replaced by guanine at subsequent DNA repair and replication. And we are not editing BCL11 itself, but we are editing hemoglobin 1 and 2 promoters. So we're eliminating the binding site for BCL11A without disrupting other BCL11A regulated pathways. Now, the consequences are interesting. Number one, the median number of cycles for the collection of adequate stem cells is 1, low. Number two, the neutrophil and platelet engraftment time is almost reaching the time of the engraftment for a haploidentical transplantation with 17.5 and 19 days on the median. And here the question is it the difference of a double strand break versus a single strand break that these cells, after they're thawed and they're eventually nested in their niches, need the time to recuperate and recover from these double strand breaks versus single strand breaks that is the reason for the shortened time to engraftment. And we can also consider now or philosophize about the fact that what is the consequence for secondary off-target effects if you have a double strand break versus a single strand break. Of course, at the moment, we cannot answer these questions, but we should keep in mind. Outcomes, again, the swimmer's plots that we know very well are excellent on 31 patients here. One patient succumbed during the treatment, of course, as a consequence of a severe busulfan-related pulmonary complication. So it's again busulfan that is an issue in this treatment as well. The data are slightly different. When we look at hemoglobin apheresis, we see a more than 60% hemoglobin F editing here. So we're down now to the real proper trait level with a hemoglobin S expression of 34% only. Percentage of F cells, very high, as in the Vertex trials, and hemoglobin F per F cell is also fairly high, enough to avoid further hemolysis. Now, in conclusion, we have all the benefits on the left-hand side, highly efficient, no donor problem, no GVHD, no risk for rejection, and a lower risk for viral complications. But, of course, it remains a surrogate therapy. We're not curing sickle cell disease or thalassemia. We're providing an alternative so-called functional cure with upregulation of hemoglobin F. We have a limited track record, so we still don't know yet what is going on in the next 10 years with secondary malignancies and off-target effects, and that might be the case more so for double-strand breaks rather than for the single-strand breaks. Poor mobilization and delayed engraftment are significant issues that are affecting our hospitals. We need the beds, we need to carry on with our transplants, and our nursing forces are limited, so this is something on a daily basis that might be an issue. Real-world data need to be collected with regard to the incidence of veno-occlusive disease and other complications and all the other factors that we need to keep in mind. So here the numbers have to be cranked up in order to give a proper answer. And of course, there's a persistence in patients of alloimmunization and hemolysis because this is something that you cannot cure with an autologous transplantation. And we talk about in a minute about the eligibility beyond clinical trial criteria. And last but not least, I think the costs. Are transplantation and gene therapy competitive treatment options? Well, let's look at the slide again, and then let's analyze how many patients with sickle cell disease, in this case, live in countries that can afford gene therapy. We're talking about, as you heard before, 2 million for the product itself, plus approximately 300,000 to 500,000 for the treatment procedure in hospital. So 10% reside in high-income countries. And of those 10%, only approximately 30%, that's 3% of the world population, are eligible for gene therapy. Why? 15% approximately, 20% apheresis failure, 15% matched donor availability, age over 35, that is not in the licensed indication, 20% approximately, and approximately 20% do not have an indication according to vaso-occlusive crises in the preceding 2 years. But what we're going to do with patients with chronic pain, osteonecrosis, progressive organ damage, hyperhemolysis, chronic hemolysis, and transfusion dependence, etc., etc., etc. So a substantial number of patients will be treated basically off license if you still want to apply gene therapy here. Same is true for thalassemia. 5% reside in high-income countries, and approximately 45% of those 5%, again, around 2 to 3%, will be eligible for gene therapy due to similar reasons: age, donor availability, and iron-related complications that make a gene editing approach dangerous. So the significant unmet need for a cure for the majority of world sickle and thalassemia patients is an issue, and we have to tackle that. And the question here is a haploidentical transplantation a feasible alternative, matched sibling and mud transplantation, or even to gene therapy? So we're back to alternative donors for stem cell transplantation, and I'm going to talk about haploidentical transplantation. The benchmark at the moment here is Adetola Kasim's publication in 2025 in Nature, New England Journal of Medicine Evidence. They analyzed in the end 42 patients, 2-year event-free and overall survival 88 and 95% respectively. But this is, of course, a very natural issue, I would say, related to post-transplant cyclophosphamide, which is a chronic incidence of chronic GVHD of 22%. And I think this is something that is very difficult to get rid of, in particular in this patient population. The alternative that we are propagating in Regensburg for the last almost 15 years is a haploidentical transplantation with a mitra alpha beta T cell depletion. And this is the regimen that we're using more or less unchanged for the last 15 years. We're starting with an immunocellular therapy with ATG grapholone of 15 and 10 milligram per kg for the haplo and for the matched sibling donor setting with a different timing, as you see here. We have a FDT approach with thiotepa, fludarabine, and treosulfan. And treosulfan is used because it has a very low end-to-end epithelial toxicity, doesn't pass the blood-brain barrier, is not metabolized in the liver, and it clearly showed in our setting that it is a very easily handleable drug with a high efficacy, as you will see in a minute. This is flanked by a post-transplant immunosuppression prolonged up to 240 days with MMF and tacrolimus to achieve GVHD-free survival for the matched siblings and to raise the level of chimerism in the haplo setting. Expectations were with a high stem cell dose, we achieve early engraftment, low rates of infectious complications, shorter hospitalization, and hopefully next to no acute and chronic GVHD. So the challenge was fairly high. We started in 2013. As I said before, we had this pilot series of patients where we directly compared matched siblings with haplotransplants, 24 and 44 patients respectively. Median age was 23 and 14.6 years. And here are the outcome data. We have an overall survival of 96 and 89% respectively, disease-free survival of 96 and 91%. Those that needed a retransplant had a disease-free survival of 100%, as expected, a significantly better time to engraftment for platelets and neutrophils with the haplo setting, and basically next to no significant complications. Acute GVHD only grade 1 to 2, fairly low. Chronic GVHD only mild, that resolved within 8 to 12 months post-transplant. And also the incidence of VOD was negligible and was mild. Now, based on these data, we engaged in a prospective stratified trial directly comparing haploidentical transplantation with a matched sibling donor transplantation, the primary efficacy endpoint with a composite endpoint, acute GVHD, chronic GVHD, primary graft failure, and death. The trial is currently running in several countries in Germany, Austria, and Switzerland, and we're going to initiate also Italy, possibly Canada, and also a center in Turkey. We enrolled so far 67 patients, and most recently we presented the data cut with 47 patients at the last EBMT meeting. So we compared 24 and 23 patients. The median age was 15 and 12 years in this setting. And these are the interim results now of this prospective multi-center monitored and controlled trial. We have an overall survival of 100%, a disease-free survival of 97 and 87%, 92 and 87%. Again, time to engraftment was significantly better. And again, a negligible incidence of acute and chronic GVHD and any other complications, in this case, viral complications. Now, I compared here the data, as you have seen from the trial, with the data from the pilot series in Regensburg. And what is remarkable is number one, the overall survival increased to 100%. And at the same time, the incidence of acute and chronic GVHD within the trial was reduced significantly. Not much of an explanation for this besides we started with a letermovir prophylaxis in 2019 in all of those patients with a mismatched CMV constellation. Definitely the cause for fatality because we lost all our patients in the early phases due to CMV infection. But I think also it could be the reason for the lower risk of or lower incidence of acute and chronic GVHD due to the lack of the inflammatory response to a viral reactivation. So further data hopefully will show this. Now, the progress of the trial is like this. We combine now the pilot series that was treated exactly identical with the trial series together. We have 35 patients. The statistical analysis, sorry for the busy slide, but in the end, it clearly shows that the outcomes are absolutely identical, so that we are now closing the reference arm and we continue with the transplantation of the haploidentical arm so that we can reduce the sample size overall to another 69 patients. And in the end, we have very solid prospective, directly comparative data between the standard of care, which is matched sibling donor transplantation, and a alpha beta haploidentical transplantation in this setting. What about TDT? Being encouraged by these results, slowly in 2016, we treated thal patients accordingly, and now we have a comparative analysis between 10 and 17 patients in this setting. Exactly the same conditioning. We don't do any pre-transplant immunosuppression, no hypertransfusion. We just do the classical approach in these patients where we do fertility preservation. We transfuse the patients immediately prior to transplant and go into transplant. And these are the results here. Again, an overall survival of 100%, 89% disease-free survival. Retransplant was successful. So we have 100% disease-free survival in all patients. The chimerism is excellent, as you see here. And in the end, no acute, no chronic GVHD, and in particular in the thal population, basically no veno-occlusive disease. Now, the conclusion here is we have similar results to match sibling donor transplantation for both populations. We achieve a significantly faster engraftment, reduced hospitalization, a low incidence of acute and chronic GVHD, a low incidence of endothelial and sinusoidal toxicities, no risk of graft rejection or failure, or basically a very minimal risk. And we have seen rejections in patients, for example, where the donor developed an acute adenovirus infection basically on day 0, and the same was true for a matched sibling donor who developed a parvovirus infection basically also on day 0 pre-transplant, and this was the major cause for graft rejection. So very unfortunate situations here. We will hopefully show by the end of this year data on fertility, because we're collecting our data after we have seen approximately 40% of our females receiving a myeloablative conditioning, delivering healthy children after natural conception. And this is, I think, very remarkable for a fully myeloablative conditioning. And of course, alpha beta haploidentical transplantation is cost effective and accessible. So when should we offer a curative approach? I think these criteria by Mark Walters are obsolete. We should not wait for any of these significant complications in our sickle cell population, but we should rather proceed for transplant and do not wait for the best option, because in this case, I literally like the quote by Frederick Douglass, who said, "It's easier to build strong children than to repair broken men." And with this, I would like to invite you to the Hemoglobinopathies Working Party meeting in Regensburg again in September this time, and we have beautiful weather. It will be my pleasure to host you there. Thank you very much for your attention.
Thank you very much, Selim. This is a very impressive, elegant presentation as usual. It was quite comprehensive, informative, and so a nice review of the update on the topic. So I'd like to thank you again for taking this time to prepare it. The floor is open for question.
Thank you so much, Dr. Selim.
Yes. Memon, yes.
Thank you so much, Dr. Selim. Very good and very interesting discussions. And Shahbaz from Riyadh, just to introduce myself. I like to congratulate for your work, excellent work, and we are always learning by doing a mutual discussions all the time. Two important things which I want to address today, particularly to learn from you in your experience. One is that here we offer gene therapy and numbers are quite acceptable, and we are happy that this opens the door for a hope for hemoglobinopathy patients. So particularly still the CNS indication for sickle cell anemia still is a gray area. And there are patients, I know when you have a full-blown stroke, it's not a good indication because the data is not solid yet. But where we stand for a silent history of silent stroke or TIA in the past or high TCD in general, I mean, just what's the update? Are we ready to go ahead for those patients, or still is a consideration but need more work? This is number one. Number two, for alpha beta, the data is excellent, and we have started doing this therapy here in Riyadh, so this is really a good start. So far for immunology patients, but not for hemoglobin patients yet. So the question is that what do you see in terms of viral reactivations, which is, I know, a big problem for immunology patients, but from hemoglobinopathy, I want to learn, do you see this concern also for these patients, or it's quite handy to do this thing? Thank you.
Thanks. These are very, very important questions. Well, for question number one, in our hands, the only really patient population where we are concerned with regard to their pre-transplant complications is moya. But otherwise, we are really now going for transplant even in very severe sickle cell patients. We had most recently a patient with a severe hyperhemolysis syndrome that had basically no product available. So we collected a few products before transplant, went into transplant, and now within 3 weeks post-transplant and 2 transfusions, he's doing very well. So even in that situation, we are quite happy with a very solid treatment option for these patients. So strokes are really the latest indication that we should go for, but we should go for transplant in patients with cerebral complications, most definitely. So, and we don't see any higher risk in this population doing the transplant the way we're doing it, in particular because treosulfan, as I said, is not passing the blood-brain barrier and does not cause additional endothelial issues as does busulfan. I think that's a major point here. The viral reactivation is absolutely an issue, and as I said, the major viral risk factor that we are facing is CMV. We can tackle that with letermovir. I mean, it is really a black and white situation with and without the letermovir prophylaxis. We try to stay away from the very little ones. Most of the time, we are challenged by families that have already a sickle cell patient and they deliver another child. And of course, they bring it basically from the delivery room directly to us and say, okay, please do the transplant. We don't want to face a similar situation with our second child. And those are the ones that we tell, please stay away from a transplant until you're older, I would say rather 3 to 4 years of age, because of a higher risk of adenovirus infection. That is, of course, as we know, difficult to treat, and the incidence is going down with age. And the other issue is the pharmacokinetic of the drugs is quite erratic in this age population, and up to 3 to 4 years, most of the time with some adequate care, you can avoid most of the sickle-related complications. So this is my take on that. When these patients develop viral complications post-transplant, we have a very pragmatic approach where when we see viral titers are rising, most of the time, we also observe a increasing mixed chimerism, which is to some point what we like to see. Why? Because when viral titers are rising and your chimerism is dropping, it tells us that you might develop a reactivation of autologous virus-specific T cells. And we confirm that with split chimerism analyses. So if you do a split chimerism analysis in the situation of a rising viral titer, a decreasing chimerism, it is most of the time what we call dissociated split chimerism. So we see 100% myeloid chimerism, and we see a rise of the autologous T cell chimerism. And that encourages us to, stay calm. We reduce MMF. In some cases, we start antiviral drugs and observe the situation. And in almost all cases, we're doing fine. Sometimes we're concerned if, for example, there's an adenoviral reactivation, we have no autologous viral how can I say?
With
Thank
that,
you so much.
thank you very much, Dr. Selim. We really enjoyed your lecture as usual. And with that, we conclude our EBMT highlights for physicians. I'd like to thank all the attendees. I hope you enjoyed the meeting, and we hope to see you again and again in this meeting. And I think the annual nursing event will start at 1:30 today, and I have one more announcement for our guests. I think this is just housekeeping announcement. For guests to go to reception to finish at least 4 hours before the flight. So you have to go to the front desk for the further arrangements. So thank you, and please, you can go for lunch now and prayer. Thank you.